Hi everyone. So you're working your full arrest and suddenly you get ROSC. End tidal shoots through the roof. You got a pulse. Now what are we going to do? Starting right now. So you have ROSC, return to spontaneous circulation for your full arrest. Yay. What are our priorities now? What do we need to be thinking about? Starting with the airway. First thing, we're going to start throttling that oxygen back. Arterial blood gases, when they drew PO2s post-arrest on patients, what they found is that a PaO2, the partial pressure of oxygen in the arteries, if it was greater than 300, was associated with poor outcomes. So let's talk about the PO2 for a minute. A normal blood gas PO2 is between 80 and 100, give or take the literature you read. That's on room air. So a predicted PO2 should be about 5 times the FiO2 you're giving to the patient. So on room air, right, 21% oxygen, 5 times, 20, 40, 60, 80, 100, okay, I should have a PaO2 between 80 and 100. If I'm delivering 100% oxygen to the patient, what's my predicted PO2? 500, way too high. So as soon as we get ROSC, we're gonna start throttling back that oxygen. How do you do that in the back of an ambulance? SpO2, or even in the ER, you don't have a blood gas machine right there, you're gonna look at your sats. If a PaO2 on a blood gas, let's say is 150, it's gonna be 100% on your sats. If it's 500, it's going to be 100% on your sats. So once your sats hit 100%, we have no idea how much further the actual PaO2 is in the patient. So we're going to start throttling back and we're going to use our SpO2 to titrate that. We want to get our titration between 92 and 98%. 94, 99%, but we cannot let it go over 100. We're going to start throttling back that oxygen. So you have ROSC, you take them from 100%, you cut your flow in half. If their stats are still 100%, turn the oxygen off. Yeah, turn the oxygen off. Unless the stats get below 92, then you can put it back on and titrate it to hit that range between 92 and 98%. Hyperoxia was associated with very poor outcomes with patients post-ROSC. Hyperoxia leads to the release of free radicals and it literally destroys brain cells. So we have to throttle back that oxygen. Check the tube, make sure the tube is good. Make sure it's positioned properly. The markings on the side of the tube, those centimeter markings, a good rule of thumb is you should be about 3 times the ET tube size at the teeth. What that means is if you have a 7.0 ET tube in the patient, you should have the markings at about 21 at the teeth. That's going to get you right where you want to be. At some point, not emergently, you're going to want to check that cuff pressure because someone slammed air into that. Respiratory usually have a cuffillator. It's a device that measures the pressure. It should be between 15 and 25 millimeters of mercury or centimeters of water pressure, whatever they're using. But we want to check the pressure in the cuff too. And again, throttle back that oxygen. Now, as far as ventilating the patient, we're going to monitor this and use capnography to titrate our rate and our tidal volume that we're giving to the patient. Now, the textbook says you're going to bag them 10 times a minute. No, you're going to start at 10 a minute, maybe. And the reason they say 10 is we don't want to hyperventilate the patient. That can reduce blood flow and drop their pressure. So no hyperventilation. But the only time I'm going to ventilate them exactly at 10 is if ventilating them at 10 breaths a minute gives me a reading of 40 on my capnography. So we want to adjust our ventilations to achieve a capnography between 35 and 45. 40 is right in the middle, that's your target. So we're bagging them to achieve an end tidal of 40. We're administering oxygen to achieve an SpO2 between 92 and 98%. Now, your ROSC patient is waking up. They have an ET tube in them. Any human being that has an ET tube in them wants that tube out of them. So your patient is definitely going to reach up, they're going to start grabbing for that tube, and they're looking at you scared, and you may be thinking, oh, we'll just extubate the guy, he looks good. Probably not a great choice. Better, and follow your local protocols, sedate the patient. If we extubate them and they arrest again, we're going to have swelling in that back of the airway from the previous intubation. It's going to be harder to intubate that patient. If we sedate them, we keep a secure patient, a secure airway in that patient, and the sedation is going to help calm them down and help slow the release of catecholamines, epinephrine, norepinephrine that they're releasing because they're all jazzed up and scared. Because now they're in the back of an ambulance with an ET tube stuck in them and they can't breathe. Sedate them, keep them down, and preserve that airway. Next, we're assessing hemodynamics. And we want to try to get their target blood pressure between, systolic above 90 or a MAP greater than 65. And remember to calculate a MAP, systolic plus 2 times the diastole divided by 3. And that's the pressure we want to maintain. How are we going to get this pressure up? Well, before we start pumping fluids into anybody, we're going to assess lung sounds, period. Is this patient already in a state of pulmonary congestion, pulmonary edema? And if we start giving them fluids, we're only going to exacerbate that, make it worse, and drown the patient. So before we start pumping fluids into somebody, we're going to listen to lung sounds. And you can see throughout the algorithms that we produced, anytime we're giving fluids, there's an icon that reminds you to frequently assess lung sounds. You can give fluid boluses, 200 cc's, 500 cc's, follow your local protocols for that. If we assess lung sounds and we got gurgling all through, they're in pulmonary edema, no fluids. We're going to have to go to a pressor or an inotrope if their pressure is below 90 or less than a MAP of 65. Follow your local protocols, dopamine, Levophed, some places using norepinephrine bumps. A lot of people are using that to keep that pressure up. All of those are acceptable, but again, make sure you don't throw them into pulmonary edema. Next, get a 12 lead. And you don't want to just have one 12 lead because as you're treating the patient, that 12 lead is going to change. So get an initial 12 lead, and that's going to tell you, geez, is this patient infarcting? Do we need to go right to the cath lab? Do we need to call a cardiac alert in the field to get this patient to the cath lab? If they have no signs of it, you look at their 12 lead, they have no ST elevation, they have no signs of an acute MI, we're still going to call it in and give our report and then bring the patient to the hospital. But we need to rule out, are they a STEMI patient? Next, we're going to look at the patient's neurostatus. And we're asking the question, can the patient follow commands or not? They may be intubated. You may have actually sedated them. But if you say, raise your right hand, and that intubated sedated patient raises their right hand, they're able to follow commands. Super groovy. If the patient cannot follow commands, to help preserve their neuro status after ROSC, we're going to begin targeted temperature management. And this therapy has been shown to improve neuro outcomes. The goal is to cool the body to a temperature between 32 and 36 degrees Celsius for at least 24 hours. And that's a core temperature. Okay, so no thermal scans up here. This is Foley temp, rectal temp, but it needs to be a core temperature. Okay, now the items I went through in this algorithm, they're not linear. These are all done pretty much in concert at the same time by a high-performance team. You need to practice these things. Everybody needs to know what's going on and review these algorithms frequently. Okay, this has been just a quick review of the post-arrest ROSC algorithm. I'm Mark. Thanks for watching. See you in the next video.